all over the world. For celebration of the launching of the Dentalbean global site, I organized 2 lectures. The first of all, this coming the March 29th, my first title is A Strategic Approach of the Full Mouth Rehabilitation. The second of all, this coming the April 19th, my title is Understanding of the Complication Pathway. I think these 2 titles is very big impact. So I really appreciate you guys, and then I really want you to meet in the online webinar. See you soon. Bye. Hi every doctors, my name is In-seong Jeon from Korea, one of the members of the Dentalbean Korea. Today I am very pleased to introduce the Dentalbean global site. Already many doctors joined our website. I really appreciate that. Dentalbean global site, we have several hundreds the lecture contents related to the implant field, the orthodontics, periodontics, and the endodontics. We are planning to support all the doctors, all items, all over the world. For celebration of the launching of the Dentalbean global site, I organized 2 lectures. The first of all, this coming the March 29th, my first title is A Strategic Approach of the Full Mouth Rehabilitation. The second of all, this coming the April 19th, my title is Understanding of the Complication Pathway. I think these 2 titles is very big impact. So I really appreciate you guys, and then I really want you to meet in the online webinar. See you soon. Bye. Hi every doctors, my name is In-seong Jeon from Korea, one of the members of the Dentalbean Korea. Today I am very pleased to introduce the Dentalbean global site. Already many doctors joined our website. I really appreciate that. Dentalbean global site, we have several hundreds the lecture contents related to the implant field, the orthodontics, periodontics, and the endodontics. We are planning to support all the doctors, all items, all over the world. For celebration of the launching of the Dentalbean global site, I organized 2 lectures. The first of all, this coming the March 29th, my first title is A Strategic Approach of the Full Mouth Rehabilitation. The second of all, this coming the April 19th, my title is Understanding of the Complication Pathway. I think these 2 titles is very big impact. So I really appreciate you guys, and then I really want you to meet in the online webinar. See you soon. Bye. Hi every doctors, my name is In-seong Jeon from Korea, one of the members of the Dentalbean Korea. Today I am very pleased to introduce the Dentalbean global site. Already many doctors joined our website. I really appreciate that. Dentalbean global site, we have several hundreds the lecture contents related to the implant field, the orthodontics, periodontics, and the endodontics. We are planning to support all the doctors, all items, all over the world. For celebration of the launching of the Dentalbean global site, I organized 2 lectures. The first of all, this coming the March 29th, my first title is A Strategic Approach of the Full Mouth Rehabilitation. The second of all, this coming the April 19th. My title is Understanding of the Complication Pathway. I think these two titles is a very big impact. So I really appreciate you guys, and then I really want you to meet in the online webinar. See you soon. Bye. 물 꺼요.
물 꺼주세요.
한 번만. 자, 왼쪽을 좋아요. 됐어. 이거 됐고. 맞아요?
크게 해주실게요. 확 벌려주세요.
아니, 피가 크게 하시면 안 돼요. 조금만 나야 되세요. 이게 위험한 수술은 아닌데 이 정교한 작업이 필요해요. 공기주머니를 지금 잡아드리고 있거든요.
테이프 맞아드릴까요?
네? 이거 잡아 그냥.
네.
그러니까 제가 계획한 대로 그대로가 됐고요. 조금만 알보셔요. Again?
네. 22, 30, 6, 8, 9, 11, 18, 26, 38. be 14, 8, 12, 16, 21, 16.
아빠 인상 쓸 거거든. 자, 이렇게. 코핑이라고 있거든.
네.
거기 저쪽에 트랜스퍼 코핑이라고 쓰는 거 있어.
네네네.
거기서 4개를 꺼내주면 돼.
4개요? 이거
자, 인상기에 믹스처 추리자 하고. 맞춰놓은 거 있잖아. 해보셔야 돼. 알고 계셔야 돼. 알고 계셔. 네, 수술 후의 소견입니다. 처음에 계획했던 대로 지금 하악은 6번과 4번, 그리고 4번과 6번.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Good evening, every doctors. My name is In-seong Jeon from Korea. You can call me Dr. Jeon from now on. I'm very happy to be here to share the implant knowledge with everyone. For celebration of the global Dentalbean, the launching, so I organized with the Dentalbean the several topics. For the first one, today's first topic is the strategic approach of the full mouth rehabilitation. Actually, I lead this course like in Korea and also Chinese. So I think it will be helpful to everyone. So in this, some of the fixed time, the arranged time, I want to answer every question. So before starting today's topic, I got two questions first. So Dr. Jeong asked, can the PRF membrane replace the conventional membrane? This is the first question. It's very important. So before starting the today's topic, I want to answer. The PRF membrane. PRF is the platelet-rich fibrin. This is some of the material. So I want to go the whiteboard, and then briefly I want to explain this one. According to the bone defect configuration, briefly, this is the self-contained defect, and then this is the partial contained defect, and this is the non-contained defect. So according to the bone, the resorption, the configuration, there are grossly three situations. So you place the implant like this one. Here, at this time, the self-contained defect, this kind of the self-contained defect, you put the bone filler. At this time, the surrounding one is intact situation. At this time, you can cover PRF is okay. And then, but this kind of the partial contained defect, there are many variable surgical methods. Sometimes the healing cap, sometimes the cover screw, or intermediately some another component like here. At this time, if you put the sticky bone, at that time, sometimes PRF membrane is okay. But no sticky bone area, PRF membrane is not effective. It requires conventional membrane, conventional. And then non-contained defect, definitely PRF membrane, no effective. PRF membrane, many good cytokine, many good growth factor, we agree this one. Sometimes interleukin 4, interleukin 6, tumor necrosis factor, vascular endothelial growth factor, and interleukin 1. There are many good cytokines, growth factor. But even though this one, the resorption is too fast. So partial contained defect, non-contained defect, PRF membrane cannot maintain the bone filler area. But this kind of self-contained defect, sometimes PRF is okay. So if you want to use the PRF instead of the conventional barrier membrane, please think the bone defect configuration. This is the first question. Usually PRF membrane resorption within 1 week. Within 1 week. 1 week means not sufficient time for making a bone around the implant area. So only self-contained defect, sometimes sticky bone with the partial contained defect, sometimes effective. But mobile bone destruction area is not proper, this one. And the second question, what torque and RPM? So implant torque and RPM, maybe implant torque means the initial stability. So I always recommend initial stability, optimal torque is 20 to 30 Newton is okay. 30 Newton. Of course, according to the implant thread fixture design or the pitch distance, but sometimes different, but grossly, 20 to 30 Newton is okay. But if you want immediate loading is different. Immediate loading means about 30 or 40 is better. So this is the brief answer. Now I'll start today's real topic. Strategy approach of the full mouth. I think there are many kinds of the surgical field of the full implant placement. Among them, the full mouth area, full mouth implant placement is the most hardest topic because it requires conventional GBR, large GBR. It requires sinus grafting, crestal approach, lateral approach. One more thing is we have to know the prosthetic concept, the vertical dimension maintenance. So anyhow, today, in a short, even though very short time, I want to make some the guideline for a full mouth strategic approach. I already read the many courses in Korea and many countries. So this the Dentalbean global webinar. I already make 60 topics. So today is the March 29th. The next time I will talk about one by one, just from the implant remover, and then the finding of optimal bone filler, mental frame on finding, and then just one by one, I will talk many topics because we Dentalbean already many implant course, beige course, sinus course, hard tissue course, upper anterior course, complication course. But among them, I want to select the several very small topics. So I want to share more deeper knowledge with everyone. As an implantologist, I worked about 25 years. And also I am an oral and maxillofacial surgeon. So sometimes the cancer patient, at this time, the cancer remover, and then the reconstruction. And then several years later, we tried autogenous bone grafting, and then implant placement. Anyhow, this is the full mouth rehabilitation. But this kind of topic, this is the cancer surgery, not proper for the general practitioner. So today, I only focus the dental-alveolar area confined. So full mouth rehabilitation. I lecture this full mouth course above the 15 years more. So always I say, just the full mouth rehabilitation start from this slide. Edentulous state, upper and lower jaw, I want to make a 6 area. Upper zone 1, lower zone 1. And upper zone 2, lower zone 2. The 6 area approach is very important. Upper zone 1, I just call this is the intersinus area. Upper zone 2, this is sinus area. Lower zone 1, interforamen area. Lower zone 2, lower molar, above the inferior canal area. Why I emphasize this one? Because strategic approach technique is different. Sometimes upper 6, lower 6. Sometimes upper 8, lower 8. Finally, upper 10, lower 10. Sometimes mixing is also possible. Horizontal bone loss means initially horizontal bone loss. Upper jaw centripetal resorption, lower jaw centrifugal resorption. So the resorption pattern is different. But vertical bone loss means the treatment plan should be different because vertical bone loss. This vertical bone loss means sometimes you have to give up upper anterior zone 1 area. Sometimes big bone loss, lower zone 2 area, sometimes you give up this area. Do you have some guideline, the give up guideline? from my experience, upper zone 1, the vertical bone height, this is the minimum requirement, 8 millimeter here. Below the 8 millimeter, please give up upper zone 1. And then lower zone 2, this is vertical available bone, minimum requirement, 5 millimeter. Below the 5 millimeter, please give up. In point of another view, you can give up upper zone 1 area. You can give up lower zone 2 area. But reverse, you shouldn't give up upper zone 2 area. You shouldn't give up. You cannot. You must not give up lower zone 1 area. That means sinus area, we can make a bone, definitely, any situation. Residual bone, 0 millimeter, 1 millimeter, we can make a bone, definitely. And then delayed placement or simultaneous placement. And also, lower zone 1 area, this is the basal bone area, we can place anytime. Even though just remaining the basal bone, 7 millimeter, 8 millimeter, we can place several implants. You know this one. This is the all-on X concept. Sometime all-on 4, sometime all-on 5, sometime all-on 6. Anyhow, the full mouse, upper zone 1, upper zone 2, lower zone 1, lower zone 2. Horizontal bone resorption area, you can place implant anytime. But vertical bone loss combined, sometimes you can give up upper zone 1. Sometimes you can give up lower zone 2 area. So this is the treatment planning, starting from this slide. Understanding of the bone resorption pattern, sometimes give up, sometimes no give up. If the patient visits your clinic, you have to see the patient, first one, jaw relation. This is the class 1, edge to edge bite, class 3 relation here. Or second one, the lip support. For me, every day I place the full mouth rehabilitation, sometimes 12 implant, sometimes 16 implant. So your first evaluation point is evaluation of the jawbone first. And then second one, lip support. Both of them, I think the lip support is more important because lip support is a very significant guideline. Upper jaw, implant of denture or not. Of course, lower jaw, no implant of denture. Just you place the several implant, sometimes the splinting, sometimes the distal cantilever bridge. So with these two informations, you consult with the patient. Of course, it requires some the panoramic view or convexity. And then according to the patient economic status, you have to determine with the patient implant number, implant position, and prosthetic design. So anyhow, jaw relation, lip support, this is the most important two informations. I think lip support is more important here. And then, for example, this patient visited me several years ago. At the time, some doctor try 4 implant placement. This is the upper jaw area. When I saw this panoramic view, I said to the patient, this the anterior 2 implant, definitely within 3 years, failed here, failure. So, and then this implant, 1 year later, failure, and then 3 years later, 2 years later, total failure here. So finally, this patient require this upper zone 1, please give up here. And the sinus area, place the several implant here. Actually, this patient history, maybe 12 years ago, she got the traffic accident. So the very poor lip support. And then maybe this is the Lefort 2 fracture, like this one. So anyhow, I placed the sinus grafting with the simultaneous placement. Upper 8 implant here. This patient, of course, very difficult surgery because during the sinus grafting surgery, we have to control the microplate. Anyhow, I placed the sinus grafting here. Upper zone 1, please give up here. Because this remaining bone below the 8 millimeter. This patient, why I apply implant of denture? Because only one, lip support. Because of the poor lip support, it requires implant of denture. I think upper jaw and lower jaw, most strong factor is lip support. Lower jaw, no lip support. No related lip support, but upper jaw, lip support. So sometimes you can apply the implant of denture. So this is the milled bar and the retentive part. I deliver implant of denture, even though 7 implant here. Of course, the sinus grafting result highly predictable here. Sometime upper 6, lower 6. Sometime upper 8, lower 8. You know the reason. Upper 8 means you can make a 3 pieces approach of the final processes. Lower 6 means 3 pieces is okay. Lower 8 also 3 pieces is okay. So implant surgery, always I say, implant surgery, sometimes you approach by the analog method, sometimes the digital method. Some doctor only rely on the digital guidance, but that is not proper. Because according to the bone defect configuration, some situation, digital guidance is impossible. Only you have to feel the analog sensation. So my conclusion is we have to learn, we have to study analog base and digital. So I just call this is the analogical method. Combine digital method and analog method, combine. This is the big reason why we have to learn the full mouth rehabilitation. So upper zone 1, upper zone 2. Upper zone 1, usually centripetal resorption, concavity like here. But GBR is okay, horizontal GBR. And then sinus area, you can try according to the residual bone height. Sometime crestal approach, sometime lateral approach here. So you can place anytime horizontal bone loss area. And then lower jaw, this is the 6th implant. This is my favorite implant position. Upper 642, 246. Lower jaw, upper 643, 346. Upper 642, 246 means your final processes just make a one piece here. Lower jaw 643, 346 means lower jaw final processes 3-piece approach is possible. So 6 implant concept means upper jaw 1 piece, lower jaw 3 pieces is available. This is the very basic concept of the full mouth. You have to find mental foramen. You have to make an optimal distance from the midline. You have to make a prosthetic design in your head. Full mouth. I think if you ask me what is the definition of the full mouth rehabilitation, I can answer without hesitation. Full mouth rehabilitation is only one definition. You have to search. You have to find comfortable vertical dimension. This is the definition of the full mouth rehabilitation. Maintenance of the full mouth, the vertical dimension, that is the key point. This patient, very severe periodontitis. So total tooth extraction, just one by one, and I place the upper 8 and the lower 8 implant here. So at this time, anyhow, this is the 6 weeks later, this early loading, and then I start the provisional restoration. This is the kind of the conventional loading concept. So this patient, immediate placement, whole teeth area. So upper jaw 8 implant, lower jaw 8 implant here. And then provisional restoration, we have to find comfortable vertical dimension. And then this is the final result. Upper 8 implant, this is a 3-piece approach here. Anterior segment, 2 posterior segment. Lower jaw is the same. Anterior segment, 2 posterior segment. This patient, this is the 6-piece approaches with the 16 implant. And then this is the 20 years later. No implant failure. Well maintenance. Of course, during 20 years, some area screw fracture, some area abutment fracture. But grossly, implant and prosthetic design, no change here. So anyhow, this is the conventional loading concept. Or sometime immediate loading is also okay. This patient is a middle-aged man, and then at this time, I starting a surgery. So total teeth extraction, and then just one by one immediate placement here. Bilateral sinus grafting, and then lower jaw also immediate placement. Same time, immediate loading here. At this time, I placed the 8 implant and also immediate loading. So first case, conventional loading. Second case, immediate loading here. So at this time, upper jaw submerging the whole implant for immediate denture, and then lower jaw abutment connection same time, and then immediate loading here. So loading concept is the first step for a full mouth, successful full mouth rehabilitation. Right after surgery, upper jaw whole submerging here, lower jaw abutment exposure for the immediate loading here. And then 1 or 2 weeks later, upper jaw immediate denture, lower jaw immediate loading. There are many kinds of immediate loading technique. So gradually, one by one, in this Dentalbean global webinar, I will talk everything. I don't want confined only one topic. Just GBR, hard tissue management, soft tissue management, full mouth, complication, upper anterior, and so on. Every topic I will touch just one by one. And then, anyhow, this is the one of the technique of the immediate loading. So lower jaw, this is the cap level technique here. So this is the before. This is the 1 or 2 weeks later. And then this is the upper and lower provisional restoration. And then this is the final processes. Just briefly, I want to ask some question. Which stage is most important for a full mouth? This is the before surgery. This is the immediate denture. This is the upper and lower provisional restoration. This is the final restoration. Which stage is the most imperative? Definitely this one here. That means this is the provisional restoration, fixed temporary bridge. Why I emphasize this stage is important? Because at this moment, we have to check, we have to restore the comfortable, functional vertical dimension. That's the key point. Every full mouth rehabilitation follow this sequence. Surgery, immediate denture, fixed temporary, final. Among them, this fixed temporary, the provisional restoration is the most important step. Anyhow, this is the final result, and 7 years later on, still no problem here. Sometime, lower jaw, very big bone resorption in the lower zone 2 area. That means this area, as I mentioned earlier, this is the lower zone 2, below the 5 millimeter, please give up here. As a general practitioner, this lower zone 2, sometimes you give up. But lower anterior, please don't give up. Because this area, sometimes oron 4, sometimes oron 5, sometimes oron 6. I just call this is the lower oron X concept here. This lower oron X is also very important. So according to the bone amount, horizontal bone, vertical bone, you have to design treatment planning. So this is the lower oron X concept here. Because if you see the bone, you have to see the 3 factors. First one, crestal bone dimension, vertical bone dimension, and then one more thing is bone angulation. So with these 3 information, you have to determine surgical type. Your surgical type depends on these 3 factors: crestal dimension, bone height, bone angulation. This kind of the 3 information influence the ridge splitting, GBR, black bone, very difficult hard tissue management. Anyhow, these 3 information is very important. If you see this patient like this one, at this time, this patient, this is the maybe mental inferior canal is here. This is also lower right side here. Maybe this is the mental foramen, like this one. And then at this time, as I noted before, please give up lower zone 2 here. You don't have to get stress, vertical ridge augmentation of the black bone. Just give up is okay because we have another area, lower zone 1 area here. At this time, I place upper 6 implant. Upper 6 means this is the finally one-piece bridge. And then lower in zone 1 area, I can place the 5 implant. This is the oron 5 concept. Maybe next time I will talk about, I really want to talk about the tilting implant. Please don't try this one. Just the straight Angulation is okay. And then anyhow, at this time, this is the final result. Upper 6 implant with one-piece bridge. Oron 5 concept with distal cantilever, this is also one-piece bridge. Absolutely no problem, this one. Sometimes you give up upper zone 1. Sometimes you give up lower zone 2 here. So usually in-seong design, upper jaw separate in-seong is good. Lower jaw continuous in-seong is okay. This is the another topic for the next time. Because lower jaw continuous incision for the mental foramen finding first. Upper jaw, no nerve finding. So just the separate incision is no problem here. Anyhow, during the surgery, you can check the vertical dimension and then finish the surgery. Several months later, upper and lower, provisional restoration here. This is the most important step, and then this is the final processes, and also 5 years later. So this kind of the logic pattern, this is a typical full mouth rehabilitation. If you see this panoramic view, you have to think Oron X concept here. This is the mental foramen. This is also mental foramen here. So available bone area, lower anterior layer, zone 1 area. And then this area, sinus area, we can make a bone, definitely. Lower, upper zone 1, please give up here. So at this time, I place lower 5 implant here. This is the 5 implant. And then distal cantilever bridge. This is the typical Oron X concept, lower jaw. And then this patient starts the upper jaw. Actually, I remember this patient. So this member wandering the many dental university and finally visit my clinic. And then I know the reason why most university give up this patient because of the upper jaw. This is the upper right side and upper left side, very difficult surgery. But with this, the Dentalbean webinar global course, we can overcome this one. This patient, upper right side first. Bone looks very sharp. But when I see the bone is very sharp bone, that means I feel very fortunate because sharp bone means vertical bone is sufficient still. So we can use the vertical bone already. At this time, you can cutting the bone, and this bone you can graft by autogenous bone grafting. Of course, at this time, I place upper right side 3 implant here. These 2 implant palatal exposure. This implant buccal exposure. And then bilateral sinus grafting by the lateral window. Briefly check why I expose these 2 implants, the palatal side. Do you know the reason? Usually, implant thread exposure to the labial side is better, labial side. But sinus lateral window area, palatal exposure is better. That means because of the bone frame maintenance. Anyhow, because of the bone frame maintenance, I exposed these 2 implants intentionally palatal side and this implant buccal side here. So finally, this upper right side, sinus lateral approach, same time GBL, buccal GBL, palatal GBL here. So it requires very simple GBL sometime, and then autogenous bone, and then xenograft or synthetic bone, and then GBL area stabilization. Upper left side is same. This case requires sinus grafting, same time GBL. Lateral window inferior area, palatal GBL. Lateral window anterior area, buccal GBL is better. So at this time I apply, this is the palatal GBL here, and this area, buccal GBL here. And then finish the surgery. Of course, this patient wear a denture. And then 6 months later, second surgery, and then deliver provisional restoration, and then change it to the final restoration. This is the step by step. Every full mouth patient, starting from surgery. Next one, immediate denture. Next one, provisional restoration by the fixed temporary bridge, and then final restoration. These 4 steps is available. Among them, the fixed temporal bridge is the most important step. I emphasize so many times. And then every surgery should be evaluated after prosthesis. This area, these two upper right side, the GBL area, sinus area, highly predictable. And then upper left side also, sinus bone grafting, GBL area, very stable here. So anyhow, upper zone 1, lower zone 1. Upper zone 2, lower zone 2. You can give up upper zone 1, lower zone 2. So with this concept, from this concept, we have to go the next step here. So this is the typical full mouth concept here. Upper 6, lower 5. This is the very good combination. Maybe this patient is the severe resolved bone during my whole patient. Her age is the 79. This patient also, every dental university give up. Some the oral surgeon try to the block bone or distraction the technique, but failure here. This area, this is the lower anterior. This area, bone is good. This is the basal bone, of course. Total alveolar bone resorption here. But remaining bone, this is a basal bone. At this time, we have to place the implant. At this time, I place 5 implants here. Just 5. Of course, drilling is a little bit difficult. And then more and more deeper knowledge, I will discuss one by one later. Because I already organized 60 topics for the 5 years. Anyhow, this is the 5 implant with the distal cantilever. This kind of the logical approach to the full mouth edentulous patient, we have to settle down your knowledge and the concept just one by one. This patient, immediate loading I tried. And then provisional restoration, and then this is a final prosthesis. Okay, let's summarize one more time. Upper jaw, this is the 642, 246. This is my favorite area here. But sometimes you can reduce the implant number. Lower Oron X, I already comment. Upper Oron X, is it okay? It's still okay. So usually, my favorite implant position 6, 4, 2, and then 2, 4, 6. But sometimes, if you give up these 2 implants because of the economic problem, or the patient doesn't want to get a sinus grafting surgery, sometimes you can place only 4 implants is okay. This is also, distal cantilever is possible. So upper Oron 4. Upper Oron 4, is it okay? It's okay. Of course, upper Oron 4 means in case of lip support is good situation. Lip support is poor, that means implant of denture. But if the patient has a good lip support situation, upper Oron 4, absolutely no problem. Of course, 1 distal cantilever here. Cantilever bridge 5 to 5. Second premolar to the second premolar area. Because this is my favorite, the upper Oron X. Sometimes 4, 2, 2, 4. That means distal cantilever until second premolar is okay. Or if you place the implant 5, 3, 3, 5, that means your cantilever amount maybe first molar is okay, like here, 6 tooth or 6 tooth. So according to the patient economic problem, according to the patient, the character, according to the lower jaw, the configuration, you can determine upper Oron X is also okay. Sometimes this patient, this is the lower RPD, removal partial denture here. At this time, patient doesn't want sinus grafting. Not because sinus is difficult, but because only one. Patient doesn't want, some patient. Maybe psychologically some problem here. At this time, I place 4 implant here. And then, this is a distal cantilever. This is the one kind of Oron X on upper jaw, 2013. And then, this is the 1 year later, and then several years later, still well maintenance. So, lower Oron X is okay. Sometimes, upper Oron X is also okay. So, sometimes bone is very sharp area. That means you can use the sufficient vertical bone. Dr. Sarda, what do you think the pterygoid joint implant? Well, I don't try the pterygoid implant because maybe I am a poor surgeon, but I think the sinus grafting is more easier, the pterygoid implant. But if you like the pterygoid implant, I think it's okay. But during the 25 years, without pterygoid implant, I can control the sinus area. So maybe this is my preference. So I see the many situations and many cases, the pterygoid implant, it looks good. So if you don't want to touch the sinus area, you can try the pterygoid implant, very long implant. I think it's okay. Anyhow, this kind of the very sharp ridge, we can make a upper Oron X concept here. Sometime 6 implant, and then implant position moving to the anterior area here, like this one. Initially, my favorite position 6, 4, 2, 2, 4, 6. But sometime anterior moving here. So at this time, this is the 4, 5, 4, 3, 3, 4, 5, or 3, 4, 3, 2, 2, 3, 4. It's okay. And then distal cantilever 6 to 6. So that means according to the implant number, distal cantilever amount is different. Upper 4 implant, Oron X, on the upper jaw, maybe occlusion range 5 to 5 is okay. But upper 6 implant on the Oron X concept, 6 to 6 is okay. So sometime 4, 3, 2, 2, 3, 4. Sometime 5 to 3, 3 to 5. So distal cantilever bridge, just like her 6 to 6 is available. I just call this is the upper Oron X concept. Upper and lower Oron X concept is same. Of course, bone density is different. So distal cantilever amount is also a little bit different. This patient, maybe residual bone, this is a 1 millimeter bone. This is also 1 millimeter bone. Of course, this 1 millimeter residual bone, sinus grafting is not difficult. But my point is simultaneous placement. Residual bone 1 millimeter, simultaneous implant placement is no problem. But full mouth situation is different. You know the reason. Because of the immediate denture, sometimes induce the micro motion of the implant. So residual bone 1 millimeter situation, that means delayed placement is better. Only full mouth case. Partial edentulosum area, residual bone 1 millimeter, simultaneous is no problem. But full mouth is the exception. So at this time, this 1 millimeter area, simultaneous placement is not proper because of the immediate denture. So I want to move in the implant position to the anterior side because simultaneous placement here. So I'm moving to the second premolar area. I'm moving to the second premolar area. Only one simultaneous placement. And then at this time, this is the 5 to 5. And then the final process is occlusion range 6 to 6 is okay, like this one. So this is also Oron X concept. Oron X, upper Oron X, lower Oron X. That means we can allow distal cantilever. Of course, distal cantilever amount depends on implant number and implant also position. So I placed the upper 6 implant and then occlusion range first molar to the first molar area. I finish here. Of course, the sinus grafting in the GBL area highly predictable. We have to understand the pathway of the full mouth rehabilitation. Some doctor like digital guidance. Some doctor doesn't like digital guidance. According to the doctor's character and the level is different. I think there are 2 ways, analog surgery, digital surgery. And then temporization, provisional restoration also, analog making or digital making. And then final restoration also, analog making, digital making here. At this time, some doctor likes analog surgery, analog temporary, analog final. But some doctor, digital guide surgery, digital 3D printing, and then final digital final restoration. But some doctor, analog surgery, digital temporary, analog final. There are many combinations available. So according to your level, you have to determine proper one. According to some situation, you have to select proper one. So analog surgery and digital surgery, that means the guide surgery. Of course, later I will talk about the full guide surgery and the initial guide surgery. And then provisional restoration, there are many ways. Immediate loading, early loading, conventional loading. This is the fixed temporary bridge. And then final processes. Sometimes, in case of the poor lip support of the upper jaw, you can make an implant of denture. Another area, sometimes fixed type, hybrid type, you can select proper one according to the patient situation. So let's check one by one. Some situation, analog surgery, analog temporary, analog final processes. Just like this one here. This patient, I take out whole teeth and simultaneously immediate placement here. Okay, this is the upper six, lower six. This is my plan. Very fortunately, the available vertical bone in the lower molar are very good. So I can place several implants here. So tooth take out here first. And then this is the immediate placement, just one by one. And then upper jaw, usually immediate denture is better. So please insert cover screw, not healing cap. And then just drilling one by one. And then it requires a very simple GBR. This is the self-contained defect. So I place the bone filler and the PRF membrane. It's okay, this because self-contained defect. And then upper left side. This is a very simple surgery here. And then tooth extraction socket area, I try the drilling, and we can check the initial stability of each implant, and then place the implant. Of course, this is the very good self-contained defect, and put a bone filler, and then PRF membrane is okay. And the lower jaw is also same. Flap elevation, and then you marking the implant position, and just one by one, implant placement. Usually upper six implant, finally one piece bridge. Lower six implant, usually three piece bridge here. So I finished the surgery here. So this is the right after my surgery. Upper jaw, six implant. Lower jaw, six implant. Upper jaw, immediate denture for conventional loading. Lower jaw, immediate loading. This is the cap level impression here. Anyhow, this is the final result. Upper jaw, one piece. Lower jaw, three pieces. Anterior segment, two posterior segment here. So anyhow, this whole procedure only analog method. Surgery can be done by analog. Temporization can be done by analog method. Final restoration also analog method. Just the conventional impression coping, and then conventional custom abutment, and then final process here. So this is the very routine procedure. Sometimes analog, analog, analog. So this is the full mouth rehabilitation. Sometimes digital guidance, and then temporization analog, and final restoration also analog. There are many combinations available here. Of course, for me, maybe you are not beginner, you guys. So guide surgery without guide surgery, for me, no difference. But sometimes, if you want to use the guide surgery, it's okay. I mentioned full guide surgery, initial guide surgery. Full guide means just like a select guide or the one guide, or there are many kinds of the full guide. Full guide means every drilling can be done on the full guidance, and then final implant placement. This is the full guide surgery. Initial guide means only two drillings rely on the guidance, and then another further drilling can be done the conventional drilling. This is the initial guide. At this time, I try the initial guide, upper jaw. So I finish here, the upper jaw, flap elevation, and then this is the kind of the guide. This is the initial guide. Only two drilling is sufficient. Marking drill, 2.2 diameter drill. And then next one, this guide, throw out. And then another drilling can be done by the conventional drilling sequence. If we use the some implant system, your drilling start from the 3.0 drilling is okay. Because 2.2 drill means the further drilling is very hard to change the implant angulation change. So this is the very important concept for the initial guide concept here. And then I placed the several implant upper jaw here. So at this time, I place 6 implant. Lower jaw, 2 implant, lower left side. And then this is the final processes. This is also surgery can be done by the guidance, the digital guide. And then before surgery, I maintain the vertical dimension grossly. And then right after surgery, also I maintain the vertical dimension. I think this vertical dimension maintenance is a key point for a full mouth rehabilitation. And then fix the temporary bridge, and then final restoration here. Of course, this guide surgery also, this is my virtual planning of the initial guide. And then right after surgery, the exactly same guidance here. Only 2.2 drilling is a sufficient drilling guidance. And then second premolar area also, this guide, same angulation here, like this one. Anyhow, this is the result from the guide surgery here. Anterior is different. Because the anterior area, we have to drill to the palatal angulation. So sometimes this drill angulation parallel to this area, but anterior area, torque control is better with the side cut drilling. This upper left anterior is same, so same angulation here, but anterior area, more palatal torque is better. But premolar area, molar area, this 2-point drilling is sufficient. Keep the angulation and position. Anyhow, this is the guidance, initial guide drilling concept here. So anyhow, if you can use the guide surgery, it's okay. Sometimes, every case is required. Sometimes, digital. Always remind, digital guidance or digital solution have to for the dentist. Maybe next time, we have a very long time next time. So, too many opportunities we will have to share about, talk about the many topics. Today, briefly, I will talk about the time of loading. Full mouth rehabilitation, immediate loading, this is the same family here. Because cross-arch stabilization is a very important step for immediate loading. So, full mouth, as I mentioned earlier, this is the typical step-by-step of the full mouth rehabilitation. Surgery, and then several weeks later, immediate denture deliver. And then several months later, healing cap by the second surgery. And then start the provisional restoration. And then you have to check the comfortable vertical and horizontal lip support and the vertical dimension. And then you change it to the final restoration. But immediate loading means you can skip many sequence. After surgery, directly go to the fixed temporary bridge. Many advantages. And then immediate loading, this is no more old concept. This is a very new, stable concept, I think. If you believe me or not, I have about 15,000 cases of immediate loading, 15,000. Among them, maybe failed case, not above 10 implant. That means immediate loading success rate, conventional loading success rate, absolutely no difference. The point is you have to find a good conclusion, the inclusion criteria, and then how to apply immediate loading, the situation. So anyhow, immediate loading is highly predictable. So the point is, first one, cross-arch stabilization. Second one, elimination of micromotion. You can keep these two principles, you can get highly predictable immediate loading processes. Of course, immediate loading has some pros and cons. Long chair time, sometimes initial stability problem, sometimes when combined the immediate placement, the bleeding control sometimes very difficult. Sometimes you worry about the contamination. But There is all cases ruled out here. Immediate loading, highly predictable sequence. Immediate placement, same time immediate loading, I like it. I really like it here. You can overcome implant stability by your drilling sequence. Bone graft definitely require bone graft. And then flap closure, of course it require some the flap control exercise. Bone resorption, change the soft tissue profile, sometime, but that means we can control the abutment at the time before, just before the final process delivery, we can control the abutment margin directly. So every problem we can overcome here. Immediate loading, there are grossly 3 types. I lectured the full mouth course, the 15 years. I have a 3 days courses, 3 days. Maybe 24 hours lecture content in the full mouth rehabilitation. But today, I want to suggest only the strategic approach of the full mouth. Among them, just the 1 day is the immediate loading. Immediate loading, there are basically 3 pathways. Fixture level impression, abutment level impression, cap level impression. This is, of course, the analog method. Fixture level, abutment level, cap level. What depends this one? Your inter-implant angulation. Poor implant angulation area, fixture level is better. Abutment level impression area, good angulation area. Cap level means usually lower jaw area. Angulation discrepancy between 20 degrees, cap level impression is better. So, in case of poor angulation, you can try fixture level impression, just like a upper jaw. Abutment level impression, in case of good angulation, that means usually Oron 4, Oron 5, Oron 6, lower zone 1 area, because the lower zone 1, angulation making is very easy. So at this time, abutment level I recommend. And then, cap level impression, whole lower jaw area. Because the whole lower jaw, perfect angulation is sometimes very difficult. Because the lower molar area, lower anterior area, torque is different. Buccolingual torque, sometimes it's very difficult to make a perfect torque making. So, according to the inter-implant angulation, inter-implant. This inter-implant angulation, that means 3 techniques is available here. Fixture level, abutment level, cam level impression. So, immediate loading, just one by one, I briefly check it here. Fixture level means usually upper jaw. I already comment. There are many combination pathways available here. Sometimes, this patient, the vitamin D deficiency. So at this time, I want to start the flap surgery, flap-knee surgery here. Flap-knees. And then, I place the several implant here. Bone is good. Of course, if you can use the digital guide. But good bone area, with guide, without guide, almost no difference. And then, after implant placement, direct impression taking here. This is the, we just call, this is surgical impression taking here. So, surgical impression taking, and then, this is the 1 week later. 1 week later, I got a custom abutment and immediate loading processes. So 1 week later, I delivered the custom abutment, and then immediate loading start 1 week later. And then, this is the final result. This is the immediate loading. This is the final processes. Upper jaw, 8 implant immediate loading. Lower jaw, 8 implant immediate loading. And then, final processes. Still, I prefer analog. But still, sometimes I use the digital. And then, temporization, I like digital approach. Sometimes, this is the conventional analog approach. Surgery by the analog, temporary, final here. Sometimes, abutment level impression, usually interforamen area. So, sometimes analog, digital, analog. This digital temporary means you can use the 3D printer or milling machine. At this time, this is the analog, abutment level impression, and this is the final result. And 5 years later. This is the before surgery. And then without tooth extraction, this area. Without tooth extraction, because with these tools, maintain the vertical dimension here. And then insert the several implant, and then keep the vertical dimension, and then later take out the tooth, and one more implant here. And then one more vertical dimension maintenance here. And then, right after surgery, immediate loading start here. Of course, no implant failure, highly stable. Several years still, well maintenance. Sometimes, cap level impression here. Cap level means angulation discrepancy below the 20-degree area. This cap level, I make it by myself. And then 12 countries may actually use this one. Sometimes, poor pass area, I recommend cap level impression. Immediate loading require ultimate removal of the micromotion, right? So conventional immediate loading means implant 30 Newton, abutment 30 Newton, crown 30 Newton. Finally, this is the one body here. This is the no micromotion. But poor angulation area, one more component is necessary. That is the protect cap. So initially, the abutment insertion, and then one more cap insertion here. And then cap level impression means over the cap, you take a alginate impression. And then immediate loading processes. Of course, at this time, totally 5 components. First one, implant. And then inside part, abutment. And this is a cap. And this is the immediate loading temporary. 4 components here. These 4 components make a one piece. Because I want to compensate the poor angulation. So this is a very easy technique, highly predictable technique also. So of course, cap require zinc phosphate cement is necessary because we don't want micromotion. And then temporary bridge, immediate loading process require resin cement. This is red color here. Let's check one case. This patient, middle-aged woman, so upper jaw, one implant here. And the lower jaw, I try lower Oron 5 here. This patient wear a denture already. So this denture duplication first by the 3D printer. Nowadays, by the optical scanning or CT scanning, denture duplication is highly easy, very easy this one. Maybe 40 minutes, we can make a denture duplication. So anyhow, this patient, I starting a surgery here. So lower jaw, upper jaw, 2 implant placement. Skip the lower upper jaw. And the lower jaw, continuous incision, and then check the mental foramen, and then drilling one by one from the midline, and then I place the 5 implant here. This is the typical Oron 5 concept here. And then, at this time, abutment correction same time, and then cap insertion here. And over the cap, I take an impression here. And then, if you have a duplicate denture, that means chair time extremely short. Because if you have a duplicate denture, that means immediate loading within 10 minutes you can make at the chair side. Very easy here. So I place the lower 5 implant and then upper 2 bilateral molar area here. At this time, this implant surgery just only analog surgery. And then at this time, this is the immediate loading over the protect cap, this one. This is the duplicate denture. If you have this one, connection to the intraoral side is very easy by the resin cement here. And then several months later, we change to the final processes. So this is the final result. Sometimes this cap level impression is also highly predictable. This is the sequence before surgery, temporization, and then final processes. This is the before surgery. What is your first step? Please record vertical dimension, first vertical dimension. And then right after surgery, you start immediate denture. For some time it requires wax rim. And then several months later, it requires upper and lower jaw provisional restoration. And then change it to the final restoration. Anyhow, sometimes fixture level impression. In case of poor angulated area, especially upper jaw, sometimes abutment level impression, especially lower interforamen area. Sometimes cap level impression, full lower jaw area. According to the inter-implant angulation, you can select proper technique for immediate loading. This patient also, maybe this patient is the most biggest sinus from my total 4,000 sinus lateral window cases. Most biggest sinus here. Maybe this upper right side, the sinus cavity's volume size may be 40 cc here. Anyhow, at this time I make a sinus grafting, and then this finished this patient, 2001. And then, several years later, this patient lower jaw broken here. So I try immediate loading here. I want keep the vertical dimension. So without tooth extraction, first one, lower right side 2 implant placement. And then lower left side 2 implant placement here. Still maintenance the vertical dimension. Finally, tooth extraction anterior area, and then 2 implant more. This is the perfect vertical dimension maintenance. There are many pathways for the maintenance of the vertical dimension. And then, at this time, this is the cap level impression taking. And then immediate loading here. What's up? What? Okay. We will, the Dentalbean check your question. 저게 무슨 말인지 한번 찾아봐. Okay, anyhow, in case of this blistering, this area, this 2 implant angulation is good. This 2 implant angulation is good. This 2 implant angulation is good. But this 6 implant angulation is not good. How can you connect this 6 implant? Fixture level is impossible. Abutment level is impossible. At this moment, you can use the cap level impression. So this the angulation discrepancy below the 20 degree, that means cap level impression is also highly predictable here. And then this is the immediate loading here. So at this time, this 2 implant, good angulation, good angulation, good angulation. But 6 implant, not good angulation here. But I want to correct by the cap level impression. Of course, final processes, 3-piece approach is okay. There are many advantages, cap level impression here. So this is the final process, the upper jaw and the lower jaw. And then, this is 2010. I checked this patient until 2018. No implant failure, well maintenance. The point is, immediate loading, highly predictable, especially full mouth rehabilitation. I always emphasize, full mouth case, immediate loading, this is the same family here. Because cross-arch stabilization, you can overcome many methods for the elimination of the micro motion of each implant here. Today, final content is the old used denture patient. Many patients wear a denture already. Can you organize the full mouth patient? I think only 3 types is available. 3 types is okay, everything. First group, denture patient. This denture patient means you can keep this vertical dimension to the final processes. This is the first one. Second group, hopeless dentition patient. Hopeless dentition means some patients have several teeth, but severe periodontitis. So finally, take out whole teeth. Anyhow, the hopeless dentition means also have some vertical dimension. You can keep this vertical dimension to the final processes. This is second group. Final group means edentulous patient without denture patient. Right? So approach is different. Denture patient, hopeless dentition without denture patient. Among them, one first group, denture patient. And then the patient said to you, I have a very comfortable vertical dimension. That means you can keep this vertical dimension to the final processes. I think there are many ways is okay, many ways. Sometimes denture conversion by the screw detention or denture duplication by the 3D printing with the cap technique. I already showed this one. And sometimes cut the denture for a vertical dimension maintenance with the cap technique. So there are available sometimes temporarily the screw retention, sometimes cap technique with the symmetry retention, denture duplication, sometimes cut the denture for a vertical dimension maintenance with the cap technique. Anyhow, with these concepts, you can apply according to the situation, according to your knowledge, according to your skill, according to patient. We have many factors. So we have organized the many factors. You have to select proper one. Analog surgery, digital surgery. Analog and digital temporization making. Sometimes helped by 3D printing. And then finally, analog final or milling machine, just like digital here. Okay, today I briefly show the full mouth rehabilitation. This today is the final the slide here. Dynamic of immediate loading. I want to summarize the immediate loading here. It works well. Just when all steps are taken properly. Rule 1, Rule 2, Rule 3 is the same. Elimination of micromotion. Implant initial stability above 30 Newton. I recommend 30 to 40 Newton is good. And then abutment screw tightening above 30 Newton. And then rigid structure with rigid splinting is okay. That means implant, abutment, crown. Finally, act like one body. That means elimination of the micromotion. When all steps are taken properly, absolutely no failure of immediate loading. Today I emphasize full mouth immediate loading, success rate exactly same, conventional loading here. My conclusion today is very simple. Just like we have to check the 6 area of full mouth, upper zone 1, lower zone 1, 2 upper zone 2, 2 lower zone 2. And then next one, lower oronex, upper oronex. And then optimal number of immediate loading. Today I talk about only here. Lower jaw, 4 implant is okay here. Lower jaw. And upper jaw, 6 or 5 at least is better. This is the full mouth optimal implant number is better. Optimal number. So anyhow, this kind of dynamic of immediate loading, we have to start from the implant number. Today I talk about lower jaw immediate loading, upper jaw immediate loading. Please try to remember fixture level, abutment level, cam level impression. Today I write down the implant full mouth number coordination. Implant number coordination here. This is my 25 years. This is the upper jaw. This is the lower jaw here. 01, 02, 03, 04 here. 22, 23, 24, 44. 64, 65, 66. 86, 88, 108, 1010. This is my 25 years implant number coordination here. Upper jaw 0 implant. Lower jaw 1 implant. I tried 25 years. But my result is very simple. Upper jaw, lower 1, not proper here. Lower 2, not proper. Lower 3, not proper. I recommend this one. Upper 0, lower 4 is okay. 2, 2, 2, 3, not proper here. I recommend this one. Minimum number of the implant full mouth. Lower jaw 4 implant, upper jaw 4 implant here. And then next one. What is this one? 64, 65. This is the all on X concept here. Please organize. This is today whole lecture, the strategy approach. Upper 6, lower 4. This all lower 4 means all on 4. This 5 means lower oron 5. This means upper oron 6. This means upper oron 6. And then from here to here, this is the fixed bridge here. Fixed bridge, upper 6, 1 piece. Lower 6, 3 pieces. Upper 8, 3 pieces. Lower 3, 3 pieces. So today, only, even though very short time, I talk about the strategic approach of the full mouth. So implant number coordination, and then also combined with the immediate loading and the full mouth rehabilitation. Primary stability, this is your mission. Implant stability control, this is your job. Monocortical anchorage is sufficient. Sometime in the sinus area, bicortical anchorage. Insertion torque, usually 30 Newton is good. Bone density, immediate loading, at least D3 bone above. Eliminate of the micromotion, and then wide distribution. 6, 4, 3, 3, 4, 6. 6, 4, 2, 2, 4, 6. Limit cantilever, minimize occlusal force for successful immediate loading. Under preparation, limited tapping, implant length. I think implant length is also a very important guideline. For immediate loading, I recommend at least 7 mm more. Below the 7 mm, immediate loading is not proper. Sometimes submerging, protective implant in reserve here. This is a very severe periodontitis. I have a live surgery video, but skip. I place 6 implant, lower 6 implant. If you see this one, upper jaw, this is the immediate denture, lower jaw, immediate loading here. And then this is the final processes. This patient, I have a 3D printing shell area, lower jaw shell. And then this 3D printing here. And the lower jaw immediate loading here. Very, very easy method. And then upper jaw immediate denture, lower jaw immediate loading here. And then several months later, upper jaw, fixed temporal bridge. And upper and lower, final processes here. This is also very highly predictable. Immediate loading, immediate function, satisfaction here. Thank you for your sincere attention. Actually, today is the first time for a celebration of the launching our Dentalbean global website to every countries. We will support many things to the whole dentist in the world. And then, if you ask any question during my presentation, I organized with the Dentalbean the global website. So I want to get your every question, and then some the 1 hour or 2 hour. Maybe from the next time, I want to extend the 2 hours because I want to answer your every question. Don't hesitate, please. Your every question I have to answer, I can answer here. Anyhow, thank you guys joined today, and then I really want you to see you next time. Okay, bye.